Welcome to This Week in Rheumatology. This week we're covering 6 notable papers spanning risk stratification in systemic autoimmune diseases and new insights into disease pathophysiology. Let's dive in. A central challenge in managing systemic rheumatic diseases is predicting and preventing severe complications. This week, several papers offer new tools and insights, particularly for patients with systemic sclerosis, antisynthetase syndrome, and JIA. Starting with systemic sclerosis, a study in the Annals of the Rheumatic Diseases identifies a key genetic risk factor for one of its most feared complications: pulmonary arterial hypertension. Researchers analyzed over 2,300 patients across 3 cohorts and found that a loss-of-function variant in the DNA SE1L3 gene, specifically the ARG260Y variant, was associated with significantly greater mortality. More importantly, when they looked at the risk of developing pre-capillary pulmonary hypertension, this variant increased the risk by about 70%, even after adjusting for factors like age, sex, and the presence of interstitial lung disease. This finding suggests that this immunoregulatory gene plays a role in PAH susceptibility and could point toward new pathogenic mechanisms. For clinicians, this raises the question of whether genotyping for this variant could help stratify patients for more intensive PAH screening. Also in systemic sclerosis, a study in Rheumatology evaluated the immunogenicity and safety of the recombinant zoster vaccine. In a randomized trial sub-analysis involving 76 immunosuppressed SSC patients and over 300 healthy controls, the vaccine was found to be safe and well-tolerated, with no impact on disease activity or patient-reported outcomes. However, the immune response was blunted. While over 92% of SSC patients seroconverted, their antibody concentrations were roughly 50% lower than those in healthy controls. This didn't seem to be driven by any specific immunosuppressive therapy or disease subtype in this cohort. The clinical implication is that while we should be vaccinating our SSC patients, the lower magnitude of the antibody response raises concerns about the duration of protection, highlighting a potential need for ongoing monitoring. Moving to another complex systemic disease, antisynthetase syndrome. A paper in Arthritis and Rheumatology introduces a new prognostic tool for predicting mortality. Researchers developed and validated a model based on a retrospective cohort of nearly 1,200 patients from China. The final model, called the ALARN score, incorporates 5 readily available clinical parameters: age at onset, lactate dehydrogenase, albumin, respiratory failure, and neutrophil to lymphocyte ratio. This simple scoring system performed very well, effectively stratifying patients into low, intermediate, and high-risk groups with significantly different survival outcomes. With high accuracy for predicting 1, 3, 5, and 10-year mortality, the ALARN score could be a practical tool at the bedside for risk stratification and counseling patients with this severe condition. Finally, in this theme, we turn to long-term risks in pediatric onset disease. A study in Rheumatology used United Kingdom primary care data to assess malignancy rates in over 3,700 patients with juvenile inflammatory arthritis, or JIA. Compared to over 10,000 matched controls, patients with JIA had a hazard ratio of 2.2, essentially a doubling of the risk for malignancies. However, the authors rightly stress that the absolute risk remains very low. The malignancy rate in the JIA cohort was just 6.8 per 10,000 person years. This is a crucial counseling point for patients and families. While a relative risk increase is present, the absolute event rate is extremely small. This week also brought new research that refines our understanding of the molecular underpinnings of disease, pointing towards more personalized medicine in the future. In Arthritis Research and Therapy, investigators explored the heterogeneity of primary Sjogren's syndrome by integrating single-cell and bulk RNA sequencing data from minor salivary glands. Using this omics approach, they identified 4 distinct molecular subtypes, which they termed the classical immune type, ion channel type, fibrotic senescent type, and immune desert type. Each subtype was associated with characteristic gene sets and distinct local immune microenvironments. This work is a step towards patient stratification, which could be critical for designing future clinical trials and eventually selecting personalized therapeutic strategies for this complex disease. And on a more fundamental level, a paper in Nature offers new insights into organ-specific immune regulation that could have broad implications beyond its focus on inflammatory bowel disease. Researchers identified a specific subset of regulatory CD8 T cells guided by a receptor called GPR15. These cells home to the intestinal mucosa, where they control inflammation by killing activated macrophages. They found that deleterious variants in the GPR15 gene in humans are associated with severe early-onset IBD, and these regulatory cells are reduced in the gut of patients with sporadic IBD. While this research is in IBD, the discovery of a specific T-cell subset that provides organ-specific immune control is a paradigm that may be relevant to other tissue-specific autoimmune diseases we manage in rheumatology. If you only have time for one paper this week, make it the study in Annals of the Rheumatic Diseases on the DNA SE1L3 variant in systemic sclerosis. Identifying a common genetic variant that confers a roughly 70% increased risk for developing pulmonary arterial hypertension is a significant step forward in risk stratification for this high morbidity population. Here are the key takeaways from This Week in Rheumatology. First, in patients with systemic sclerosis, consider the potential utility of genotyping for the DNA SE1L3 ARG206CY variant to identify those at higher risk for pulmonary arterial hypertension who may benefit from closer monitoring. Second, in patients with antisynthetase syndrome, the new ALARN score, based on 5 common clinical variables, is a validated and practical tool for predicting long-term mortality. Third, the recombinant zoster vaccine is safe in immunosuppressed patients with systemic sclerosis, but be aware that the antibody response is significantly lower than in healthy controls, which may affect long-term protection. Fourth, for patients with JIA, you can counsel that while the relative risk of malignancy is doubled compared to controls, the absolute risk remains very low. And finally, molecular subtyping in diseases like Sjogren's syndrome is advancing, which promises to help us better target therapies and design more effective clinical trials in the future. That's your roundup for This Week in Rheumatology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.